Hi, this is Mohamed A Yassin, and I will be presenting ophthalmic manifestations as the initial presentations of chronic myeloid leukemia. So, ophthalmic manifestations are considered an uncommon presentations of chronic myeloid leukemia, and with a paucity of information in the literature. Little is known about them. There are many unanswered questions. How does CML present? Do we need to do an ophthalmic examination for every patient diagnosed with CML? If there is a cutoff point for leukocytosis that can predict eye damage, and are these effects reversible? Are there any reliable interventions? We address the emerging unmet needs for CML patients who present with ophthalmic manifestations and illustrate how to approach and treat such population. Chronic myeloid leukemia is a myeloproliferative neoplasm characterized by the presence of PCR-able oncogene and increased proliferation of the myeloid cell lines without losing their capability to differentiate. It is a triphasic neoplasm with a chronic phase, accelerated phase, and a plus crisis. Chronic phase chronic myeloid leukemia is defined as having an evidence of translocation 922 or PCR-able fusion gene, a blast count less than 10% in the bone marrow, and should not meet any criteria for accelerated phase or plus crisis as per the European Leukemia Net guidelines. Accelerated phase must meet one or more of the following criteria, plus 15 to 29% of peripheral blood, white cell count, or bone marrow cells, peripheral blood basophils at least 20%, or persistent thrombocytopenia less than 100,000 and related to therapy. WHO is having a different perspective. So the WHO criteria are slightly different with an addition of persistent thrombocytosis and responsive to treatment, and peripheral blood blast from 10 to 19%. Blast crisis must meet one or more of the following criteria, blasts more than or equal 30%, and this is the ELN criteria, while the WHO is setting a different benchmark, which is more than or equal 20% of peripheral blood white cells or bone marrow cells, extra medullary blast proliferations, and large foci or clusters of blast in bone marrow biopsy, according to the WHO criteria. CML presentations can be variables with a wide range of symptoms and signs that can even present as an incidental finding on routine complete blood count. Symptoms can include fever, loss of weight, night sweats. However, splenomegaly remains the most common initial presentation in chronic phase of the disease. With the progressive disease, the accelerated or blast phase of chronic myeloid leukemia, presentations can be similar to acute leukemia with signs and symptoms of anemia, bleeding, petechia, ecchymosis, fever, or bone pain. Ophthalmic manifestations is underreported. We consider it as uncommon presentation, and I don't think it's uncommon presentation, but there is an underreporting of the ophthalmic manifestation. An ophthalmologist, rather than hematologist, may be first to discover the CML, variably described as an incidental finding during a routine eye exam, cleared vision, or severe visual loss. The ocular manifestations may be the initial signs leading to diagnosis of leukemia, happens in already diagnosed patient, or to be found during the relapse of the disease. Ocular complications. These ocular complications may result directly from leukemic infiltrate or as a result of the associated anemia or thrombocytopenia, leukocytosis, thrombocytosis, hyperviscosity syndrome, and leukoembolization. Almost any ocular structure can be involved, and manifestations can vary from mild dot and blot hemorrhage to advanced optic nerve infiltrations. And we are going to illustrate this in the subsequent tables. What was the trigger to do this review and to think about initiating a guidelines for ophthalmic manifestations in CML? In our Cancer Institute, I encountered with my colleague 2 cases of CML that presented with ophthalmic manifestation. So what's wrong with these 2 patients? Both of them, they were young, and they present initially to ophthalmologist, and they had, unfortunately, they have partial loss of vision. And then that was very traumatizing to me. Why should a young male or female with a disease like CML in the era of tyrosine kinase inhibitor and in the era of advanced medicine lost their vision totally or partially in a reversible condition? If there is a gap in the literature, if there is something which we don't know, what about the ophthalmologist? Are they aware about chronic myeloid leukemia and they know how to treat it? What about hematologist? How much knowledge we know about ophthalmic manifestations of CML? And this was the trigger to do this presentation and to propose a new recommendations for possible future guidelines, because I think once it comes to patient care and it affects the quality of life, this is an urgency for us as a physicians to act and to propose and to come with solutions, not just to wait and to say that it's not in the guidelines. So what we have done, we have done a literature search for English language articles using PubMed, Scopus, and Google Scholars for any data up to September 22. And the following keywords were used: CML, ophthalmic manifestation, visual disturbance, visual loss, and search results were initially reviewed by title and abstract, and articles were selected for more in-depth system analysis if deemed relevant. Pertinent articles were examined in depth for this report. And we have formed like a group, which is a multidisciplinary group, which involved like 3 expert hematologists and 3 expert ophthalmologists, because we thought this is something between ophthalmology and hematology. Hematologists cannot sort it out by themselves, and ophthalmologists cannot sort it out by themselves. So let's have the bridge between ophthalmology and hematology. In the results, we found that 38 published articles were identified that described ocular and ophthalmic manifestations in patients with CML, including 36 case reports and 2 case series of 2 cases each, a total of 40 cases. The median age was 37.05 years, the range between 37.5 to 49. And 67.5% of patients were male. So as you can notice, majority of those affected patients with ophthalmic manifestations are relatively very young populations. Most of the cases were initial presentations of CML, 33 cases, and only 5 of them were a relapse. 1 patient had a relapse of eye involvement, and 2 were lost to follow-up. A total of 4 patients eventually died without improvement in ophthalmic manifestations. If you want to have the details, you can go to the table which we have published in Survey of Ophthalmology. And what we try to do, we look at we put here the authors and all the articles so that you can access it freely. And then we have also indicated the age of the patient as well as their gender, whether they are male or female, and what are the features at presentations. We looked carefully at the white blood cell count because we thought that it could be linked to leukostasis. And then we have a questions whether a platelet can be blamed, whether there is thrombocytopenia or thrombocytosis, does it play a role or not. And then also we looked at the presentation, whether it was an initial presentation or relapse, and what kind of treatment patient received, whether patient received hydroxyurea, imatinib, leukophoresis, And then what about the involvement? Is it a bilateral or unilateral involvement? And what happened to the vision? Whether the deterioration on vision, loss of vision, or the vision was corrected? What kind of investigations done from the ophthalmology side? And what happened to the optic disc on examinations? What are the status of the vessels in the eye? What are the status of the macula? And what is the outcome? You will find all these details in our table in Survey of Ophthalmology. So if you want to discuss it in brief, we can say that the first case was reported in 1971. Further cases revealed is a range of ophthalmic presentations. Some cases presented with no ophthalmic complaint. Other patients had severe visual loss. Patients presented with both unilateral or bilateral ophthalmic findings. 9 presented with unilateral CML-related ophthalmic findings. 8 of these had a unilaterally decreased of vision, and 1 had normal vision. 31 patients presented with bilateral ophthalmic findings. 4 of these patients had a normal vision upon presentation. So if you want to put a bottom line, we can usually in medicine, we have a general rule telling that if it is a systematic disease, it has to involve both eyes. If it is, but if you have one eye, it's likely a separate pathology. And even from this limited data, you can see that this is not the case. So in CML, you can have a normal ophthalmic, you can have a unilateral, and you can have bilateral. So presence of unilateral involvement doesn't exclude systematic disease. We have to keep it always in mind. Upon presentation, the white blood cell count is in almost all cases was highly elevated. The lowest number of the white blood cell count reported at presentation was 50,000, while the highest was 688. All the cases except 3 were the initial presentation of CML, and the remaining 3 cases were CML progression to blast phase. White blood cell was reported in 30 cases with a median value of 229. The median platelet count was 315. We talked in the previous slide about the white count. Now we are just shedding the light on the platelet. The median platelet count was 315 with a mean of 350 and a range of 23 to 750. Only 2 cases had a platelet count of less than 150, although only 32.5% of the articles, which is 13 cases, had documented the platelets at diagnosis. A normal median thrombocytes count suggests that thrombocytosis or thrombocytopenia may not have a role in the ophthalmological manifestations of chronic myeloid leukemia. Then we have to understand some basic anatomy of the eye as ophthalmologists. As ophthalmologists, they understand it very well, of course, but as a hematologist, we need to understand some of the anatomy. Usually the ophthalmologist is talking about the anterior segment and the posterior segment. What is the anterior segment and what is the posterior segment? Because we are going to talk in details about this. The anterior segment is the front third of the eye that include the structures in front of the vitreous humor: the cornea, iris, ciliary body, and lens. Within the anterior segment, there are 2 fluid spaces, the anterior chamber and the posterior chamber. The anterior chamber between the posterior surface of the cornea, the corneal endothelium, and the iris. And the posterior chamber is between the iris and the front face of the vitreous. Aqueous humerus fills these spaces within the anterior segment and provide nutrients to the surrounding structures. This cartoon is, illustrating what do we mean by the anterior segment. And here you can see the anterior chamber, the posterior chamber, and you can see all these structures which we have described if you want to familiarize yourself with it. What happens in the anterior segment involvement? If there is an anterior segment involvement, it can present as anterior uveitis, hypopyon, or blood-stained hypopyon, iris infiltration, and rubeosis. Why we emphasize on this? Because if you have patient with chronic myeloid leukemia and you send him to ophthalmologist, then you need to tell the ophthalmologist what is expected in patient with CML, so that you don't mix between what is CML related and what is non-CML related. So ophthalmologist and hematologist should be on the same line, and they should know what are the manifestations related to the disease. Only 4 out of 40 cases had an anterior segment involvement. Anterior segment involvement was bilateral in 2 cases. Only 1 patient had complete recovery of the presenting features, hypopyon and rubeosis. 1 patient with iris infiltrates had no visual improvement, and 1 with a persistent anterior uveitis and hypopyon had a relapse, and 1 with bilateral hypopyon and rubeosis lost follow-up. So we have no further information about it. What about the posterior segment? What is the posterior segment? So we understand now what is the anterior segments and what is the relations between CML and anterior segments, and what are the things we should look for as a hematologist, or we should ask our ophthalmologist to look for in the anterior segment. Then what is the posterior segment? The posterior segment, or the posterior cavity, is a back 2/3 of the eye that includes the anterior hyaloid membrane and of the optical structures behind it. The vitreous humor, retina, choroid, and optic nerve. The portion of the posterior segment visible during ophthalmoscopy or fundoscopy is sometimes referred to as the posterior pool or fundus. So most of the clinicians telling I am doing a fundoscopy. So what are the posterior segment involvement in CML? In posterior segment vasculopathy, secondary to CML, is more common than direct leukemic infiltrations, and we can show this in the subsequent tables. The most common findings are leukemic retinopathy, which is the rotted spots, cotton wool spots, leukemic infiltrates, pre-retinal hemorrhage, intraretinal hemorrhage, subretinal hemorrhage, dilated tortuous vessels, optic disc hyperemia, and retinal vascular sheathing. These findings are mainly secondary to vascular stasis due to a very high white blood cell count. Proliferative retinopathy may occur as a result of hyperviscosity that is causing peripheral non-perfusion and retinal ischemia, resulting in new vascularization of the disc. And retinal new vascularization include like C-fan new vascularization. This predilection for the proliferative retinopathy in CML depend on the extent of retinal ischemia that results in capillary dropout. Proliferative retinopathy may result in vitreomacular traction, vitreous hemorrhage, and tractional retinal detachment. Macular and foveal involvement have been reported multiple times and can cause profound visual loss. Rarely, leukemic cells invade the vitreous cavity and cause vitreolitis. If the choroid, which is the most vascularized tissue of the eye, is involved, this may lead to choroidal infiltrates, exudative retinal detachment. Other findings like optic nerve swelling, infiltration may cause severe visual loss. Additionally, retinal vein occlusion was presented in 1 case. This cartoon, again, demonstrating what do we mean by anterior segment or posterior segment, and we have demonstrated the types of pathology which ophthalmologists can expect to see in patients with CML when he or she examining the anterior or posterior segment. Then, if CML ophthalmic is related to high white count, can we do a leukophoresis and cut it short? While leukophoresis can be considered as an emergency treatment, there is a little evidence that it changes the outcome. The best approach to treat the underlying malignancy. Patients can have multiple pathologies leading to concomitant ophthalmic manifestations, making an accurate diagnosis more challenging. As progression in diabetic proliferative retinopathy is from ischemic angiographic stimuli, it may be worsened by concurrent CML retinopathy, causing increased blood viscosity and vascular endothelial growth factor level. So this is a proposal to categorize ophthalmic manifestation in CML to mild, moderate, and advanced. In mild, we have examples like we put what can be classified as mild, like retinal hemorrhage or rotis spots or the others. And in moderate, if you have a proliferative retinopathy or hypobion or retinal vein occlusion. Advanced, if you have optic disc infiltration, executive retinal detachment, or choroidal infiltration and hemorrhage. So the management of these ocular manifestation is mainly by treating their cause, which is CML. This was the only treatment in mild cases. Just to re-emphasize, this is the only treatment required for mild cases. Thus, an urgent referral to hematology is required. And what about the moderate and advanced cases? In moderate and advanced cases, however, both systematic treatment and ophthalmological intervention, such as laser photocoagulation, intravitreal injections, pars plana vitrectomy, and inoculations may be needed. So in moderate and advanced cases, it's always better to involve ophthalmologists because the systematic treatment for CML alone doesn't work. Clinically evident ocular involvement is common in patients with leukemia and has been described in up to 50% of patients at diagnosis. Patients who are otherwise healthy but present with a decreased vision and picture mimicking ischemic retinopathy, retinal hemorrhage, and vascular abnormality should be considered to have an underlying blood dyscrasia, such as anemia or leukemia, until proven otherwise. A detailed medical history should be obtained upon presentation, focusing on causative factors such as trauma, diabetes, hypertension, coagulation problems, and vascular diseases. What about ophthalmic examinations? What kind of ophthalmic, if I am a hematologist and I got a patient who's having a visual acuity problems in CML, and I'm sending him to ophthalmologist, he will ask me, what kind of exams you want to do it, you want me to do it for him? So usually what we recommend is to do the visual acuity of both eyes should be documented, then a slit lamp examination of both anterior segment should exclude any evidence of other causes of decreased vision. The ophthalmologist may find signs pointing to CML, such as ciliary congestions, anterior uveitis, hypobion, or neovascularization. Dilated fundoscopic examination reveals the presence or absence of vitreal reactions or hemorrhage like rotis spots, cotton wool spots, leukemic infiltrate, optic disc, to rule out any edema or hyperemia or neovascularization of the disc. The macula should be examined to rule out the pre, intra, or subretinal hemorrhage, foveal mottling. Retinal pigment epithelial changes also should be looked for. The retinal blood vessels to rule out hemorrhage. Sheathing, attenuation, dilated and tortuosity of the vessels, vein occlusion or neovascularizations, and any peripheral signs of ischemia. Specific ophthalmic investigation that can aid in the diagnosis and managing disease, one of these is optical coherence tomography, or what is abbreviated as OCT, can aid in the diagnosis of macular pathology, such as edema, levels of hemorrhage, foveal mottling, levels of macular involvement. This is a OCT, how does it look like? And this is just to let you familiar about how does it looks like. If you want to have more details about the OCT, you can review our articles in Survey of Ophthalmology. Then what are the specific ophthalmic investigations that can aid in diagnosis? We said, in addition to the previous, fundus fluorescence angiography can be helpful in revealing occult neovascularization, ischemia, or PRP pathology. Then we have the B-scan ultrasonography, which can help to diagnose retinal detachment, subretinal or choroidal pathologies such as mass and hemorrhage. Visual evoked potential, or the VEP, may help identify optic nerve involvement. The treatment described includes wide range of modalities for CML, hydroxyurea, which was used as an immediate cytoreduction therapy in around 50%. Many cases were treated with surgical interventions plus cytoreduction therapy with hydroxyurea followed by tyrosine kinase inhibitor. The cases before the year 2000 didn't receive TKI as it wasn't exist. One case was treated with the radiation to the eye, another with intraocular Avastin, and another with corticosteroid to reduce the edema. The cases with extremely high blood vessel count were managed acutely with leukapheresis. 3 cases were treated with surgery only. In 17 cases, imatinib was used as a TKI. 2 cases used bosutinib, and in 2 cases at our institute, we used nilotinib. Imatinib is therefore the most used TKI, and maybe because it was the first available TKI and has been recommended as first line in CML treatment over much of the period. We could not find the so-called score component in most of the described cases to calculate the risk score, and if imatinib would still be considered the drug of choice if cases were treated today. In ophthalmic management, in the patients with anterior segment involvement, one of the 4 had no posterior segment finding. The initial diagnosis was non-granulomatous anterior uveitis refractory to steroid, which was later diagnosed as masquerade syndrome. The patient was started on local radiation therapy, and his ophthalmic finding resolved. What about the other ophthalmic management? Another patients had concomitant rubiosis iridis and proliferative leukemic retinopathy, along with hypopion. Ophthalmic findings ultimately resolved following chemotherapy. One patient had iris infiltration, eventually underwent inoculation because of the refractory pain, even after chemotherapeutic agent and corticosteroid treatment. In one patient with hemorrhage, hypopion anterior chamber paracentesis revealed neutrophils predominantly. His bone marrow biopsy ultimately showed blast crisis. Then the patient was lost follow-up. What about patients with posterior segment pathology? In the posterior segment vasculopathy secondary to CML is more common than direct leukemic infiltration. The most common findings are leukemic retinopathy, which manifest as Roth spot, cotton wool spot, leukemic infiltration, pre-retinal hemorrhage, and the others. These findings are mainly secondary to vascular stasis due to a very high white blood cell count. Proliferative retinopathy may occur as a result of hyperviscosity that is causing peripheral non-perfusion of the retinal ischemia, resulting in neovascularization of the disc and retinal neovascularization, including like CFAN neovascularization. The predilection for proliferative retinopathy in CML depend on the extent of retinal ischemia that result in capillary dropout. Proliferative retinopathy may result in vitreovascular traction, vitreous hemorrhage, and traction retinal detachment. Macular and foveal involvement have been reported multiple times and can cause profound visual loss. So patients with posterior segment pathology, rarely leukemic cells invade the vitreous cavity and cause vitreitis. If the choroid, which is the most vascularized tissue of the eye, is involved, this may lead to choroidal infiltration and executive retinal detachment. While leukapheresis can be considered as an emergency treatment, there is little evidence that it changed the outcome. The best approach to treat the underlying malignancy. What about the outcome? The outcome were divided into one of the three groups: resolved, meaning back to normal; improved, indicating the condition became better but did not completely resolve; or not improved. We choose to adopt those three categories because they were favored by many of the investigators. It can be seen that some of the ophthalmic changes are reversible while the others are not. Ophthalmic manifestations can also categorize by severity into mild, moderate, and advanced by the region of involvement on presentation requiring ophthalmic interventions and by visual prognosis. So what we recommend? If the patient presents to ophthalmology first with a sudden or unexplained visual disturbance and is found to have retinal or vitreous hemorrhage, an urgent complete blood count and peripheral smear should be done on the same day, and this is a message to ophthalmologist. Similarly, if the patient presents to ophthalmology first with a sudden unexplained visual disturbance and has a retinal or vitreous hemorrhage, an urgent CBC and peripheral smear should be done. If the white blood cell count found to be high, then referral to hematologist should be done immediately. If the white blood cell count are found to be significantly elevated, not explained by other causes such as infection, then hematologist service should be also consulted. If CML is diagnosed, cytoreduction with hydroxyurea should be initiated urgently, followed by tyrosine kinase inhibitor therapy when appropriate. So if the patient present to hematology as a new CML case with a high white blood cell count, then proper referral should be made to ophthalmology for dilated fundus exam and to rule out ophthalmic manifestation of the disease. We recommend using a cutoff value for high white blood cell count as more than 100,000, which should alert the clinicians about the possibility of having ophthalmic changes. There is a high possibility of hyperviscosity syndrome with a white blood cell count more than 300,000. There should be a close collaborations between hematologists and ophthalmologists for better management of ophthalmic manifestations of chronic myeloid leukemia. If no urgent intervention is required, patient with ophthalmic manifestation should be initially managed by a hematologist. Once treatment has been started and stabilized, surgical interventions can be planned if conservative measures and systematic treatment do not resolve the ophthalmic manifestations. So to conclude, we can say that CML can present in various ways, including rare and unique ophthalmic presentation. An eye problem may be the first presenting symptoms of CML and requires an urgent evaluation with view to the early commencement of therapy. There are no widely accepted guidelines regarding treatment, but consideration should be given to cytoreduction with chemotherapy or leukophoresis and starting tyrosine kinase inhibitor. Delay in treatment may result in irreversible damage to the eye. Close coordination between hematologist and ophthalmologist is important. If you want further data, you want to do further review of the subject, we have more illustrations in our review and survey of ophthalmology. And at the end of this presentation, I would like to thank all the colleagues who worked together to put an outlines for this very important unmet need. I would like to thank my wife and my family for their continuous support. And I would like to express my deepest gratitude to the International CML Foundations for bringing people together and supporting CML patients and CML community by having this series of presentation. Also, I would like to thank all my close friends, my mentors and supervisors, and all my patients. Thank you very much.